Good day, Patrick Henry. This is Mr. Ray. This is the second of the two mini lessons that have been included in the resource section of the gradebook. You will need to use this to fill this out. Both of these, again, are in the resource section of the gradebook. Once you finish filling this thing out, using the lesson to help you as we go along, as we go through this, make sure that you send it back to me through Dropbox so that way I can give you classwork credit for your time, effort, and energy. Then to go through the lesson. This lesson will be on therapy. It is worth noting that this is the companion part to the previous lesson on disorders. For the previous one, looks at ways in which people have and grapple with some of these mental conditions. So the therapy piece, in at least an overview form, we look at ways in which some and many of those conditions can be treated and addressed. So if you fill this out as we go through, on the front side of this, we're looking at insight therapies, talk therapies, and behavioral therapies. It is worth noting before we go much further with this that modern day therapy doesn't use any one particular perspective. It uses whatever works best based on the patient's needs. So for example, if you were seeking a therapist because of OCD, I would dare say that psychoanalysis would probably not be the way to go. However, one, if not more than one of the other ones, would be very effective. A term that we looked at earlier on in the year, eclectic psychology, will be drawing from each and all of the perspectives and using whatever works best based on the client's needs. Having said that, the first of these will be psychoanalysis or psychodynamic psychology. Some names that should go with this that you would be aware of and should be familiar with would be Karen Horney, would be Carl Jung, would be Alfred Adler, and of course the godfather of this field, Sigmund Freud. Although they differed on the specifics, the one common ground that they all kind of operated from would be the need to probe the unconscious. And no matter what their approach, at some point, if you were seeking one of those individuals or somebody operating from their principles, if you were to see them, you would have to talk. Well, from a psychoanalysis standpoint, that is referred to as free association, where you just talk. Whatever comes to mind, uncensored, unfiltered, and the therapist would be listening for common themes and the different things that you've said. Also, dream interpretation is very big in Freudian psychoanalysis. If I were to mention to you a dream I had last night in which I was being chased, what I just described to you would be the manifest content, as that is the plot, the narrative of the dream. If a therapist were to take that and say that being chased represents unconsciously me running from something, that would be the latent content, the interpretation connected with it. Do keep in mind that dreams, Freud called them the royal road to the unconscious. Because we have very little control over it, it is essentially your unconscious coming out to play. From the humanistic standpoint, some names that you should be familiar with, connected with this perspective, would be Carl Rogers and Abraham Maslow. Both of those individuals focused on the self, as there are a lot of self buzzwords connected with humanistic psychology. Free will and role models. The focus would be on the whole person, because that is probably the reason why they're seeking therapeutic help to begin with, for there's something on the inside that is broken. Carl Rogers, this is a term that we looked at earlier on in the year, client-centered therapy. Basically, in anybody that's using his techniques in his therapy sessions, it is all about the client. Because outside of that room, it's not about them. Maybe they have very few friends. They don't view themselves in a positive way. You're trying to make that entire experience all about them. Unconditional positive regard. No matter what they say, always positive feedback. Also connected with Carl Rogers would be reflexive listening, where no matter what the client says, they will always receive positive feedback, and paraphrased, paraphrasing whatever the client said and repeating it back to them, but in a non-confrontational, supportive manner. From the cognitive angle, moving on, rational thought is the key to change. We've talked about before self-fulfilling prophecies, that many times they are negative, but they don't have to be. If you change the thoughts, you can change the person, which is the basic thinking behind Aaron Beck. Positive thinking, that if you change the thoughts, you can indeed change the person for the better. For that is probably the reason why they're seeking out a therapist to begin with. Okay, on the right side of this are the behavioral therapies. Classical conditioning, operant, and observational learning. Classical conditioning, you may recall from the beginning of third 9 weeks, you're looking at very, very simple, basic behaviors. Names that come to mind with this would be Ivan Pavlov and John Watson, who is the father of behavioral psychology. These are very simple behaviors that are addressed using these therapeutic techniques. Systematic desensitization. The person may be focused or have an issue with a phobia, and if you are tackling it systematically, you are slowly facing your fear. But maybe the phobia is not so bad. Exposure therapy may be the technique that would be most appropriate, where you face it head on. Aversion therapy tends to be very, very good and somewhat controversial depending on how it is used in dealing with addictions. Aversion therapy, you add something unpleasant, making the addiction unpleasant for the person. All right, operant conditioning. Now, classical is very simple, basic behaviors. Operant, though, you are manipulating voluntary actions. Some names that are connected with this would be B.F. Skinner and Edward Thorndike. Contingency management, behavior modification. Simply put, you are manipulating the rewards and punishments of the individual. So maybe they have never truly been rewarded for good, appropriate behavior. So you do so consistently. Maybe the kids have never been consistently punished. So you manipulate these things to get desired, shaped behavior. A token economy, we've talked about this before. Maybe when you were a kid, mom and dad had a chore chart for you. Or maybe your elementary school teacher used a color system. Both of these are using a token economy, or secondary reinforcers are being used to change the behavior. It can be very, very effective if the kids buy into it. Observational learning techniques is the last of the behavioral ones. A name that should be connected with this would be Bandura in his Bobo the Clown experiment. And as his experiment implied, and in a therapeutic setting, participant modeling, you would learn appropriate behavior by watching. Now, before we flip over, the last of these, cognitive behavioral therapy, or as it is sometimes called, CBT, you are combining the best of cognitive therapy and behavioral therapy. An early pioneer of this was Albert Ellis. Now, a little bit to write in this blank. Sometimes it is spelled out completely, and sometimes it goes by these initials, REPT, Rational Emotive Behavioral Therapy. You change the thoughts, you change the behaviors, you change the person. So an individual suffering from obsessive compulsive disorder that does not want to be medicated, or maybe it's not bad enough to warrant medication. Whenever they feel these obsessions coming on, whenever they are tempted to indulge in compulsive behavior, maybe to direct those mental energies and those actions towards something more positive. If you flip over to the other side of this, we're looking at treatments from a biomedical pharmacology standpoint. A term that's up at the top, this is more of a cautionary tale, tardive dyskinesia. Sometimes when you watch or see these medication advertisements on TV, they will go through the laundry list of side effects, and every so often tardive dyskinesia is mentioned, but motor control issues that can be caused by extended antipsychotic use, almost in the form of a twitch, maybe facial twitches or hand tremors could be the result of it. Many times these things subside once the person quits taking the medication. Or maybe the medication is too strong and they're put on a weaker dosage. But anyway, tardive dyskinesia is one of many, many potential side effects connected with these things. For you're altering the brain's chemistry either chemically on this side or physically on this side of the sheet. Antipsychotics. Generally, these are given if one is suffering from a schizophrenic episode, seeing and hearing things that nobody else can. Arrow going down. These medications would lower dopamine levels, as elevated dopamine is oftentimes cited as a cause of schizophrenia. The schizophrenic medication would lower dopamine levels. Antidepressants would be for depression. Arrow going up, medication that is taken would increase serotonin levels, so it would be an agonist for serotonin, as antipsychotics would be an antagonist for dopamine. Mood stabilizers, lithium being a very, very common one, oftentimes used to treat bipolar condition. Now, if you know notice with the arrows, they are both going up and down. Bipolar condition would be a very difficult one to treat because you are basically treating two conditions in one. You are treating the manic, over-the-top state and the depressive state. But glutamate would be one of the key neurochemicals that this medication is meant to manipulate. Anti-anxiety drugs would be used to treat anxiety and insomnia. And GABA being the main calming neurochemical, any anti-anxiety medication would contain an agonist for this neurochemical. Stimulants will oftentimes, ironically enough, be used to treat ADHD. On the right-hand side, maybe much more invasive surgery is needed. Psychosurgery, we have talked about some of this before. Lobotomies and lesioning. And do keep in mind that the stuff on the right side of this, psychosurgery and electroconvulsive therapy, these are operations and procedures of last resort. Psychosurgery, oftentimes used for extreme seizures, like cutting the corpus callosum. Electroconvulsive therapy, or ECT, or shock therapy, as it is sometimes called, is used for extreme depression. More and more I'm hearing commercials for this on the radio, and again, it is a procedure of last resort. You have exhausted all other alternatives, for you are, if you notice, you are inducing a mild seizure in the person. And then the last part of this isn't so much what you're doing to the brain, but altering things in society. Because if all of these things are to no avail, where do you put these individuals? What agency is going to take care of them? Deinstitutionalization, starting in the late 50s, early 1960s, there was a move to empty and close down the state-run asylums. But do keep in mind that these individuals and these patients have to go somewhere. Sometimes they're able to get support through local treatments. In particular, if there is a family member who can make sure that you take your meds and that you see the appropriate specialist. But do keep in mind that this runs a very, very big risk, because what if those local facilities are not existent? Or what if the individual's insurance doesn't cover these things? Or what if the person simply doesn't want to go and there's nobody in their family to make sure that they go? Homelessness. A disproportionate amount of individuals that you see out on the street, many of them are suffering from a mental condition. A number of individuals also, veterans out on the streets, or maybe for whatever reason they are unable to or unwilling to seek treatment. When you hear people speak of the mental health crisis that this country faces, this is essentially what they're talking about. When you finish filling this out, make sure that you send it to me so I can give you credit.